everyone. I'm hoping you can hear me. I can't see anybody else. I think there are other people here. Should we give it a couple of minutes?
Yeah. It says 4 people waiting on YouTube.
Okay. How do I let them in? Oh, there's no one in here, you mean? Oh no. Yeah, I think it's on. I don't think people are waiting. I think if you click the link, I'm hoping people can see us. But when I pull up the YouTube link, I can see myself. So I'm hoping that means that it's working. If people are happy to leave a little comment on underneath just to say that you can see and hear us both, that would be great. Yeah? Fab. Okay. It's 6:31, so we don't keep everyone late. Let's just crack on. My name's Izzy. I'm one of the FY1 co-leads. I'm an F2. I live in South Wales, in Cardiff, and work down in here in South Wales. And we've got Nicola with us as well.
Hi, I'm Nicola. I'm one of the F2s in Kings Lynn at the moment. And yeah, we also have another person who's with us, Maria, who sadly can't be here today. But we just want to say, like, we totally understand what it's like being an F1 and all the struggles that come with that. So we're here to help you guys. And yeah, you can always email us. We have an FY1 Mind the Bleep email. So we're here for you guys. And hopefully this webinar series will also be really helpful for you guys too.
Yeah, okay. So I'm gonna turn you off, Nicola, and I'm gonna start sharing my screen, and we'll crack on with the first presentation. All right. Okay. I'm hoping that my screen is being shared. If it's not, Nicola, just drop me a text and let me know. But I'm going to crack on regardless. So. This is our series that we've created. This is the first session. I'm going to lead this one myself. But it's called Confessions of an FY1. And the idea of the series is essentially to give you guys kind of practical and specific helpful information to support you through F1, particularly thinking about on calls and making decisions independently, maybe in the middle of the night, maybe about something you've never seen before. And we've got lots of wonderful guest speakers lined up who are going to draw on our own experiences of being an F1 and things that we came across that we weren't maybe expecting or prepared for, to try and help you be a little bit more prepared than I was, perhaps. Yeah, so let's crack on. This is the three of us. That's me on the left, Nicola in the middle, and Maria, who's not with us this week, is on the right. So yeah, that's us. And as Nicola said, when you email the FY1 page email address, that's who you're emailing. So yeah, thanks for joining us. So this week, let's get on with it. We're talking about interpreting imaging, the sort of investigations, particularly from a radiological perspective, that you need to be kind of comfortable interpreting and knowing what to order and when. So the goals from this session are, I want to have an understanding of what you as a group feel less confident in, so I can kind of focus more on the things that are helpful specifically to people listening live. I'm going to go through some cases, and I'm going to give you some tips from things that I've seen myself on the wards as an F1. Most of these are things that I've sort of seen in the middle of the night when I'm on my own and panicking. So don't worry if you haven't come across these things yet, or maybe you have and it's traumatizing. We've all been there, and hopefully give you a bit of better confidence in knowing when to escalate, when to call your seniors, and how to present kind of imaging that you find. So I'm going to start off with a Mentimeter. If people are able to scan the QR code, just to it will be rolling throughout the presentation. So if you just keep it open on your phones, I'll give people a second to scan it. And then the first question that we have is just for me to gauge, these are the topics I'm going to cover today, and just to get an understanding of how confident you feel knowing when to order and knowing how to interpret the following 4 topics. I think there's a little bit of a lag from the streaming to the video, so I'll give you a bit of time. And there's the code at the top if you didn't manage to catch the QR code. Okay. I hope this is coming up in real time for the same as you as it is for me. I'll just refresh this. Yeah, okay, so a bit of a range. More confidence for chest X-rays and abdominal, but not many people that are really, really confident, and much less so for cardiology stuff and neuro. Okay, fab, thanks everyone. And I know that Mentimeter works, so at least I can in some way have some interaction back from you guys, which is a bit nicer for me as well. So just also get a little bit of background. This is something I always ask the students that I teach, is how prepared do you feel for, how confident did you feel for medical school with regards to ordering and interpreting investigations in FY1? So did you feel like medical school prepared you properly? Okay. Bit of a mix. I'll just refresh this. Okay. Got some answers trickling in. Not at all, I'm overwhelmed. That was me as well. In fact, most of the time that is still me, so please don't worry. I'm glad no one is here, because you don't need to be on this call if that's you, but good for you. Okay, let's crack on. Oh, actually, there was one more thing I wanted to... Oh, this is just before we actually crack on. If there's any specific investigations that people want us to cover, now's your chance to kind of shout out, and we may not necessarily be covering it today, but it's useful for future, for us to pass on to the people covering other topics. But if there's nothing, that's absolutely fine. Happy just to go with the flow. Okay, no worries, fab. Let's crack on. So I'm going to start off with chest X-rays, straightforward. This is just a very brief kind of overview of the advice I was given on the respiratory wards. Oh, somebody said ECGs. Sorry, I missed that. Fab. I don't have any ECGs on this, but this, I think we get this a lot, and we've got a cardiology series coming up, and we have asked them to cover ECGs, so don't worry, your time is coming. Yeah, talking about X-rays, just to cover the basics, just in case this hasn't been covered before, because a lot of medical schools don't do dedicated radiology teaching. And I will preface this with, I'm not a radiologist, I'm an F2, so this is kind of what you need to know for an F1 level. This is not kind of expert guidance, but air is dark and dense things are light. And there's this idea of, when you're presenting a chest X-ray, just describe what you see. Don't necessarily, you don't have to diagnose from chest X-ray, especially not in F1. You're not expected to know which lobe you're actually talking about, because you're talking about a 3D structure in a 2D film. So it's very, unless you are incredibly confident, it's fine just to talk about a pacification and shadowing generally in the lower mid zone of the left lung. Because that is accurate and that is true, and that's what you can see. And difficult to confidently say, oh, this is consolidation, i.e. infection in this lobe. And I always use an ABCD approach when I'm describing. So when the consultant on call says, or the consultant on the ward says, oh, here's an interesting chest X-ray, what do you see? I will go through in an ABCD format. So airway is the trachea central. B for breathing. So can I see lung markings all the way to the border? And if not, where do they go up to? And are they uniform? Is there congestion? Is there patchiness? C for cardiac. So the heart shadow, is it more than is it less than 0.5 of the thoracic cage, as long as it's a PA film? Can I actually see the borders of the heart? If you can't see it, don't say the heart's a normal size. You can just say, I can't appreciate the heart borders. And then D for diaphragm. So can you see the costophrenic angles? And can you see any air under the diaphragm as well? And then E for everything else. So if you can see surgical emphysema, if you can see an obvious deformity of the bone, if you can see something just weird and wonderful, tubes, drains, pacemakers, comment on it at the end. And that's the way that I go through every single time I'm interpreting a chest X-ray, especially if I don't really know what's going on. Okay, so I've got a bit of a ward cover watch list scenario. Oh, sorry. I think there's a bit of a lag. Is it still lagging? I hope not. I'll just... Is that better? I think there's a bit of an echo. Is everyone, hopefully everyone is muted. I don't think Nicola's still on. Okay, I'm going to carry on. So often in the evening, if you're on medical cover, you'll get a list of all of the jobs for the evening, and you'll just have to work through them on your own and prioritize them and keep going. So let's say you've got this 73-year-old female, chest X-ray requested at 4:30 p.m. Please chase a film and action any findings as appropriate. So if you have a look at the 6 chest X-rays, let's just imagine these are the 3. You're sat down in the mess and you're pulling up all the films and seeing which ones you need to see. So have a quick scan. And the task on hand is to rank the films in order of clinical priority. So these are the 6 that you've pulled up. Which ones are you going to see first? And which patient's going to have to wait till the morning? I should say I've gone in 1, 2, 3, 4, 5, 6 order. Okay, let's refresh this. We've got some answers. So people starting with 2, and then, oh, it's a little bit even Stevens for 2 and for 4 and 6. Interesting. And then some people starting with 2, and most people have left this one and this one till the end of the day, which I have to say, I think I agree with. Let's refresh this. Okay. I think fair enough, very sensible. There's not necessarily a right or wrong here. I'm going to talk through each of them briefly. So starting off with these two. So we've got two chest x-rays here. Both of these patients probably quite chesty sounding and infected. This one we're probably all very comfortable with. A is normal, B is normal over here, and you can see there's a big area of increased shadowing that's quite well defined in the left lower zone, in the right lower zone, sorry. And this one, there's sort of generally increased patchiness throughout. You can see this patient's on oxygen, and this patient's probably a bit older, and I think this patient is going to present quite a bit sicker than this one. If it was me, I would see this one much sooner than this one, because I think with this sort of picture of bilateral patchiness that's not that well defined, I'm going to be thinking in my head, has this person aspirated something? Has this person vomited? Are they intoxicated? Have they fallen in the canal? This sort of chest x-ray where it's bilateral patchiness, just think, could this be aspiration? So personally, I'd go and see this one first, see that one later. Next, we've got these two. So both pleural things, both, this one, if you're going through them both, they've both got central tracheas. They've both got good lung markings and costophrenic angles on the right-hand side, and the left-hand side, they've both got homogeneous area of opacification where you can't appreciate any lung markings. But the main difference between the two of them, and most of you will know this is obviously a pleural effusion, is the thing that gives it away is this meniscal sign, which basically tells us that this is probably some sort of thin serous fluid. Whereas this one, you've got this weird tracking up here. And probably if you check this patient's blood work, their CRP is going to be over 300. It's going to be ridiculously high. They might be immunosuppressed. They might have had a chest infection for a long time. But this to me looks like empyema is what I'm going to be thinking if I'm seeing spooky looking effusion of some kind that tracks. There's no meniscal sign. So it's probably a horrible, sticky, thick yick that needs to be drained. But depending on the respiratory compromise of each of these would change who I went to see first. But if in doubt, I'm going to probably see this one first. Although this person does have some medial spinal shift, so they may be feeling a bit more breathless, but this one needs antibiotics ASAP really, and they both need draining. And if I saw either of these overnight, I would call the med reg. Whereas this, I'd manage myself. This I'd manage myself if they were okay. Whereas these two, I'm immediately getting help because something weird's going on there. And the final comparison is these two. This, I thought that people would rank this as the first one, but not everyone did, and that's fine. This is a classic image of a tension pneumothorax, which really, I think, very infrequently do you ever actually see these chest x-rays because it's a clinical diagnosis, and these patients will come down to A&E, they're never going up to the wards, and they're getting cannulated straight away to release the air. But I wanted to touch on it just because you will pick up pneumothoraces that will look more like this one, or potentially even be sort of in here and the whole lung's collapsed. But the signs of tensioning that you want to keep an eye on are mediastinal shift, which will include, if we're starting with RA, you can see here a nice central trachea, and this one, whoop, trachea is off to the right. B, there's complete absence of lung markings in the affected lobe, and you can see it's all squashed up and adjusted over here. And there's diaphragm flattening, which is the other sign that someone's starting to tension. So if you see a pneumothorax and they've got a nice curved diaphragm like this one, the pressure in the lung is okay. As soon as that diaphragm starts to go flat, we're starting to get into problems. It's tipping over into medical emergency, pull the buzzer, call everyone type land. And when you get to E on your AT assessment, you'll notice that this patient has a lovely chest drain. And after patients have chest drains put in, somebody, usually the FY1 late in the evening, goes through the watch list and has to have a look at all of the images and make sure they'll do a post-chest drain insertion x-ray. And what you want to see is that it's placed nicely. There's a little bit of fluid here, but that there's not a great big, hemothorax. You want to see that the lung is starting to reinflate. And my advice from my own experience is, if you're looking at a chest strain, chest X-ray, just go and eyeball the patient and just go and physically see them, make sure that they don't look like they're struggling and that it's poked in somewhere funny, and have a look. That you'll see their little chest strain pot, that tube there connected to a pot that's full of water, and the pot will be sat on the floor, and just have a look at the pot, get the patient to cough, and when they cough you should see the water going up and down in the tube, and that's called swinging, and you'll see some little bubbles coming out the bottom, and that's bubbling. And just document in the notes that you've seen that the chest strain is swinging and bubbling, and the patient's comfortable, and that's fine, that's good enough. But I just recommend that you at least cast an eye over them, to make sure that they're not sort of panting and puffing away and they've poked it through the other lung. Yeah, so whilst you're checking these chest X-rays, you get a call, you get a bleep from the nurse, and the nurse says, "Doctor, my patient's becoming really breathless. Can you come and see them, please?" And you're thinking, "Oh, I've got 55 jobs that I need to do. What information?" This is just open-ended, so there's not really any right or wrong answers. Well, there's loads of right answers, no wrong answers. What information from the nurse do you want to know before you even go and see them, to help you prioritize? Yeah, past medical history. Love it. Yeah, OBS, perfect. Let's refresh this. I don't know if you can see it. Yeah, fab, saturations, respirate temp, repeat OBS. How long have they been in hospital? Yeah. Yeah, asked to do bloods and repeat OBS, very sensible. I agree with everything. Sometimes I like to ask the nurses, especially if you know the nurses, the nurse on this ward, I will just ask, "How worried are you about this patient?" Because usually they're pretty good at, they will either be like, "Oh, he's a bit short of breath, but I'm not worried." And sometimes they'll be like, "Actually, I'm really worried. You need to come and see them now." And that's when I'm breaking out a sweat to go and see them. Okay, fab. Oh, there's loads more. Sorry. OBS trend. Yeah, current bloods. What we're treating with oxygen demand. Yeah, I agree with everything. This is wonderful. So, in answer to your questions, because I thought you might say that, those are his OBS. So he's got heart rate of 118. He's chugging along at a bit tacky. Oh, someone else has said DNA, CPR in place, and ceiling of care, which is very, very, very wise. That is a great question. What is their ceiling of care? How much do I need to be running, or do I need to be walking to see this patient? Yeah, really, really helpful. So his respirates are 32, he's saturating 86% on air, and he's got temperature of 36.8. His blood pressure is 100 systolic, so that is a News of 10. He's a post-op patient on the TNO ward, and he had spinal surgery 3 days ago. He hasn't really walked since. He's a smoker, he's a diabetic, and he's got BMI of 33. So what investigations, this is what the nurse has told you, and you've just turned up, you're running along. What investigations do you want to do for this patient? I'm sorry, I've just refreshed it now, sorry. Yeah, chest X-ray, I agree. CTPA, very sensible, good to be a PE. He's post-op, so yeah, it's a very good point. ABG, yeah, completely agree. Let's refresh this. Bloods including a D-dimer, ABG. Yeah, very sensible. A2E assessment, yeah, perfect. Always the A2E. We love the A2E assessment. ECG, chest X-ray. I agree with everything. I agree with everything you've said. That's just, yeah, standard rest workup. If in doubt, get an ABG, get chest X-ray, and do an A2E assessment. You cannot go wrong doing that. So let's scale 1 or 2. Yeah, very good point. This patient is a smoker. Is this oxygen, I mean, it's still a little bit low, but is it only a little bit low for them, or is this, like, are they actually coping quite well with that? Although respirator 32, probably not. So you get a portable chest X-ray, because you look at him and you think, there's no chance I'm getting this guy down to X-ray, and that's what you see. So we can't have, unfortunately, people can't unmute to talk through it themselves, so I'm just going to have to talk through it to you. And those are his bloods. So this chest X-ray, you can see up here, it's mobile, which is always a bad sign. So the technicians have to come to them rather than them go to the tech. Central airway. There are lung markings all the way to the border, but I would describe this as widespread bilateral patchy opacification across all zones of the lung. So top to bottom, there's no effusion. I can see the costophrenic angles-ish. I can sort of see the heart border, although it's a bit obscured by the patchy shadowing. And the eagle-eyed amongst you might think, seeing this here, is this a bit of bat wing appearance? And those are his bloods. So I'm thinking, has this gentleman had a heart attack? And the next question is going to be, as the FY1 on call overnight. So this has happened at 2:30 in the morning. You haven't seen your reg in 6 hours. What is your management plan for this patient? Other than panic, if you're me. But this is very similar to a case I saw, and my number one first move was to panic. Someone said, call the med reg. Yeah, very sensible idea. Get some help. ACS protocol. Yeah, it's not a bad thought. He clearly, this is probably cardiogenic. I would say I do agree, but I would, in terms of like, is this man having a heart attack? I wouldn't anticoagulate him, but I do agree in terms of like pain relief and oxygen, that sort of stuff, especially because some opioids might help bring his respiratory rate down in this instance. Yeah, someone said high flow, oxygen, and some IV Fruzy. I completely agree. For this case, so this is pulmonary edema, and it's probably cardiogenic, but at that, I would say the dealing with the heart stuff is secondary to this. Furosemide, someone said, yeah, the first thing I would do for this patient is grab the nurse and some extra, grab an HCA and the nurse looking after him, and one of them needs to stay in the room at all times while you go and prescribe some furosemide, whack some high flow oxygen on him, give IV Fruzy. I mean, 40 I completely agree with, but you could go, I mean, go big or go home. You could give 80, you could give 100. You're not going to be able to, well, you could overdo it, but a healthy dose of furosemide. And I agree with this. Alert a senior. For this patient, to be honest, you wouldn't be, if you call the med reg and the med reg doesn't bleep you back or doesn't come over immediately, to be honest, I would, oh yeah, someone's just said exactly what I'm about to say. I'd put out met call personally. So if you see a chest X-ray like that and the patient has got a news of 10, that patient is probably about to die. This is like a peri-arrest territory. That chest X-ray is really, really bad. And I can't emphasize this enough, because every now and then there's been 2 like this I've picked up as an F1, and I'm like, you don't know what to do with it, but give some furosemide and put a met call out. And yeah, review meds when you get a chance. Yeah. So this is the sort of thing where you need to be, I mean, get as many people as there as you possibly can, as quickly as possible. Yeah. Oh, sorry, I've left that there. But yeah, this is, if you see this, it's panic time. Pull the alarm, get people out there, especially with a news of 10. That patient will get tired very, very soon. So give them some Fruzy, get the fluid out, sit them upright, and put out a MET or a peri-arrest call. Yeah. So let's move on, because I've spoken about chest x-rays for a long time. Abdominal x-rays. So we don't use them that much. They can be really, really helpful for some things, but CTs have sort of overtaken abdominal x-rays, because if someone's going to go to surgery, they're going to end up having a CT anyway. What's the point in faffing around with an x-ray? But there are some instances where they're really, really useful as a quick, low dose of radiation, and it's easy to do as a first port of call if you're not sure and you feel like the abdomen's surgical, but you don't really know what's going on. So there are some classic signs that you might see on x-ray. This is the first one. Does anyone know what this is called? And no worries if you don't. You can also just describe what you see if you're not sure what the sign is. Thumbprinting. Oh, you're not wrong. There is a bit of thumbprinting, a little bit. Although I don't think these are massively. Well, they probably are a bit inflamed. Yes, although the sign that I'm talking about is this, where the white arrows are here. It's not a coffee bean sign, but I will say, hold that thought. This one, so this is called Wriggler's sign, which is where if you have air inside the abdomen, it produces this really nice, like, standout appearance of the bowel. So normally the bowel's just all kind of smushed together and you can't really make head of tails. But when there's air inside it, you get these really nice outlines of the bowel loops, because you get dark air contrasted against dark air with the white bit in the middle. It's called Wriggler's sign. Oh, sorry, gone back. So that's that. Oh, someone's put Wriggler's. Sorry, I didn't even see that. Yeah, spot on. And I only learned this recently, so you're miles ahead of me. This next one, anyone know what this sign is called that we can see on here? What condition do you see this? If that's that Wriggler, so anything that's caused air to get into the abdomen, so usually we're talking about a perforation, would be typical, or I guess any kind of penetrating wound, but normally we're talking about bowel perf and air leaking out into the abdomen. Pneumoperitoneum, yeah, that is exactly what this is. So again, air is the dark, and then air dark in the lung, and then you've got this line which is the diaphragm. But the specific sign, so it's called continuous diaphragm sign, when you see this nice line like this and it comes in like a nice arch. But yes, it's the same thing. Perforating ulcer, yeah, perfect, all correct. And then the last one, this one we've already had a bit of a spoiler. This is where the abdominal x-ray kind of comes into its own, and we order these loads. If anyone, I mean, it's already on here. So it's a coffee bean sign, because it looks like a big old coffee bean. And we do these again and again because as you get old, and especially in patients that suffer with chronic constipation, so often in elderly patients, the kind of fibers of the colon, of the large bowel, can like stretch and elongate, and sometimes the large bowel gets longer and longer and longer, and it gets like saggy. And sometimes you'll see large bowel that, rather than being like bish bash bosh like in the diagrams, actually it goes up and then it kind of loops down here and then comes down, and eventually in many people that loop, you know, it just ends up twisting on itself. And once it's got all stretched and saggy like that, it's quite difficult for it to, like, it doesn't go back. So patients that have volvulus often tend to have it repeatedly. So you're not going to whack them in. You know, they come in, they've had it 100 times, you feel their belly, it feels like a big balloon, you know what it is. You don't need a CT, then you can get a quick x-ray to confirm the diagnosis, and then you can just use a flatus tube, hopefully, to decompress them. So it's really good in that instance. Coffee bean, yes. Yeah, exactly. Fab. And this is the sort of thing you might actually see, but we do see these sometimes. Okay, the one thing with abdo with like abdominal, well, I guess surgical X-rays and things, even though it's just X-ray, is NG tube placement. So there's 4 kind of criteria that I use in my mind to make sure if I'm documenting. So let's say they haven't managed to get any aspirate from the NG tube, and they've tried and they've tried and they've tried, they can't get any aspirate. So they send down for chest X-ray. Although I think some trusts, everyone gets one, but anyway, that's not the case where I work. So the NG tube, firstly, you should be able to see it, because sometimes the patients pull it out on the way down, and then you look at the chest X-ray and there's no tube. So check you've got the right patient. It should travel centrally, and it should bisect the carina. The carina being the bifurcation of where the trachea goes into the bronchi. So you can sort of see that faint lucency here. That's the carina. So it should bisect the carina. It should pass the diaphragm, and ideally centrally. And you have to be able to see the tip of the tube. If you can't see the end of the NG tube, you just can't say that it's safe to feed. Even if it goes down and it bisects the carina and looks all sensible, if you can't see the end of it, you mustn't feed them. And you might need to just retract it a little bit, or rescan a bit lower, and so on. And then check that they haven't done anything silly. Quick check for pneumothorax. And then they're good to go, they're good to feed. And I think the first few times I confirmed it via X-ray, I felt so nervous, because without the aspirate, I was like, oh my goodness, how do I know it's in the right place? But it is. If you follow these 4, it definitely is in the right place, and they're safe to feed. So in the last sort of 20 minutes, I wanted to go through a couple of, so mostly a bit of cardiology and a little bit of CT head, and just cover some things that I found as an F1. So my first job as an F1 was cardiology, which meant I was doing medical ward cover, and I didn't feel like I had much preparation for it in medical school, and there were lots of things I was expected to sort of understand that I actually didn't. So we're going to discuss what I think you need to know as an F1 doing medical on-calls with regards to awareness of angiograms and awareness of TTEs. And you don't obviously need to be able to interpret them or whatever, but just I think it's really important to have an understanding of what you're requesting. And we learn at medical school, oh, you do TTE to look for structural defects or in heart failure or whatever, but what does it actually look like? And when your patient says, oh, the consultant told me that I have an ejection fraction of 35%, what does that actually mean? To have an understanding, to be able to explain it in simple terms, and then to have a quick look at the chest X-rays that are ordered after pacemakers have gone in, because you will often have to be the one 4 hours after they have their pacemaker put in, or ICD, they do an X-ray to make sure the leads are in the correct place, and it's up to us to make sure that they are. So you just need to have an awareness. So this is an angiogram. This is how it looks. Here's the heart, here's the apex of the left ventricle, and here are all the lovely vessels. These are nice healthy ones. The left circumflex, obtuse marginal, the LAD is going around there, and it goes off into the diagonal, and that's the left main trunk. And if somebody has stenosis or very badness, and they get anginal pain, it looks like this. So that pinching off there is just where the artery is full of plaque, basically, and that's how it looks on the angiogram, and that's what gives the pain. So all of the stuff downstream from here, and all of the heart muscle that's being supplied downstream from there, suffers basically and undergoes a bit of ischemia, and that's what gives them the pain. So that's what happens when they have their angiogram. And if you do a cardiology job, I really recommend that when your patient goes for their angiogram, just have a look at the images, because they're really cool. And you can see the little heart beating away, and see if you can spot where the stenosis is and identify the arteries, and just makes it a bit more fun rather than going around being a secretary for the consultants, which sometimes happens. So yeah, it's nice to have a little look at the images yourself. And the same thing for the transthoracic echocardiograms, or TTEs, or just jelly scan of the heart, as we say to the patients. Basically, they whack the probe on here, and if you do see the physiologist going around and do them, I think it's worth popping your head in and saying, "Can I have a look?" Because it's quite cool. There's a like a sternal axis, which is looking through that way, and there's an apical axis, which is looking through the apex, like directly up through the heart. And just to give you kind of a vague awareness, it basically looks like this, and you see the heart beating away. And the probe is here, so that's the angle you're looking from. So you've got your ventricles here, and then your atria up here, and you can see the valves and the septum. And so obviously the reason that these are so good for looking at structural defects of the heart is you can actually see the heart muscle pumping away. And sometimes after a heart attack, you'll see, you know, one side's going crazy, going hell for leather, and the other side's just sort of vibrating because it's basically the heart muscles died, and they would report it as hypokinetic wall. And sometimes you'll be able to see fluid around the heart, and so they can, you know, they'll use it in myocarditis, pericarditis, tamponade, looking for vegetations, infective endocarditis, all sorts of stuff. And then when they apply the colours, that's when they're looking for direction of blood flow. So I remember it as BART, as in B-A-R-T, blue away and red towards the probe. The probe sits up here, and here you can basically see the blood is going from the left atrium to the right ventricle. So it's going from here to here. And then when the left atrium to left ventricle, when it's squeezing, this is a faulty leaky valve. So it's shooting up there, and you're getting regurgitation. So this is mitral regurgitation because the blood is flowing away from the probe back into the left atrium where it shouldn't be going. So it's quite a nice way of, that's what it looks like, and that's how they see it. So it's why it's, you know, quite good for diagnosing valve pathology. Although the transesophageal is kind of gold standard for looking at the valves. Yeah, so that's kind of what they're going for when they have their jelly scans. And yeah, as I mentioned, just to touch on the pacemaker x-rays, because my first ever on call, I had to look at a few of these, and I didn't have a blue clue what I was looking for, and it just said on the watch list, please check for our post-pacemaker chest x-ray, make sure the leads are in the right place. And I thought, I've got no idea where the leads are meant to be. I don't know what I'm looking for. What are the complications? So that you know, and you don't have to call up the med reg like I did. The things I look for, firstly, can you see the device and is it vaguely in the right place? Eyeball the patient and just make sure they look okay. Is there enough slack in the leads that when the patient raises their arm up, it's not going to pull and displace the leads? There should be a little bit of slack. And if it's a nice thin lead like this, it's probably just a pacemaker or a CRT-P. And here are the leads, and you can see one's in the atrium, one's in the ventricle. And if you've got a thick coils like this, that's the shock part of it, basically. So this is going to have, so these are the shock coils, and one sits in the right ventricle and one sits in the superior vena cava. And so they have a defibrillator element to them. It's not like we don't need to necessarily be able to see, oh, it's a CRT-D or whatever, but that's the thick bits of the shock coils, basically. And so you want to have a look. You can see this is in the right place, bit of slack here, patient looks fine, and the leads should be going down and one should be going up. And in order to check lead placement, you need a lateral chest x-ray. So if they haven't got one, send the patient back down to x-ray, get a lateral view, because you can't actually say from just looking at it this way. You need to look at it side on. And the extent to which I would document is that they look like they are sort of in the right position, and the consultant will see it in the morning, but one should be going down and one should be going up. And you get a sense of, like, these two, you can see they're both going down, and here they're together. They're both in the left ventricle, or the right ventricle, sorry. So they've gone together. And whereas these ones, they're just going wee-woo, they're all over the shop. And actually, these look okay, but there's also, there's a pneumothorax up here. And so the other thing that you want to check is that they haven't poked the lungs, specifically in the apices. So it's quite difficult to see, but there's actually no lung markings in the apex of the lung up here on the left side. And if the reason that we need to know this is if there's a massive pneumothorax, does it need a drain? Does it need management? Hopefully not. In this case, probably not. But if the leads are in the wrong place, they're going to need to go back and have it revised. So you don't need to be able to say exactly where they are, but if it looks wrong and you're not confident, call the med reg, get them to have a look, because the patient might need to go back and have it revised. And then, yeah, check there's not a pneumothorax or a hemothorax, or they've poked it out somewhere completely random. And yeah, just document that in the notes. So in the last kind of, I don't want to keep you too long, because it's the end of a long day for all of us. The last thing I wanted to touch on is CT heads. Nobody expects you to be able to interpret a CT head. I certainly can't. With CT heads, if you're interested in imaging and you want to improve, I can't recommend enough, when you order a CT head, and if you work on the wards, you will end up doing them. If you work in A&E, you will do hundreds of them. But every time you get it back, before you get the report, when they've gone for the scan, just have a flick through yourself, and you get same for CT abdo-pelvis, CT heads, CT thorax. Have a little flick through, and the more you do it, the more you kind of it's just fun to test yourself. And sometimes you will see things, and you might not know. Like, I never know what it is, but sometimes you can see, oh, they've had a stroke, or they've had a bleed, or there's something funny in the abdomen. I don't know what it is, but let's see what the report says. But on the wards, you will find, or you may find, that when patients fall, it can be quite stressful when you're on your own to know, should I be CTing this person? Shouldn't I be CTing this person? And I just wanted to signpost you to the NICE guidelines, which are really specific. They're really clear. For adults, they've got one bit on people taking anticoagulation, but they've got like really specific adult and child guidelines that you can follow, and you can't go wrong if you follow the guidelines, and that you don't have to CT everyone that falls, even if they've hit their head. You don't have to CT them, and it is your clinical judgment. And sometimes you will have people asking you, like, oh, just do the CT, just do the CT. But there's some interesting articles in the BMJ from last year about the prevalent, how much we're CTing people, and trying to reduce the amount that we're doing it, just because of healthcare costs, radiation risks, patient flow, and so on. So you don't have to do it if you don't want to. Not if you don't want to, if you don't need to. And I found it really, really hard at first to not CT someone that had had a fall, because it felt like the most cowboyish, riskiest thing in the whole world. But not everyone that has a fall needs a CT. So one of the difficult things about being a doctor is that responsibility and clinical judgment and decision making. But the guidance is there to help you, and if you follow it, you really can't go wrong. And the same to signpost for young people, because if any of you have worked in peds, or particularly if you've worked in peds A&E, it's just kids that have had head injuries is just constant. As I say, I work in South Wales, and it's a big rugby community, and I mean, we see so many kind of 10 to 15-year-olds with rugby injuries, and thinking, do we need to scan them? Do we need to scan them? But for someone under the age of 18, it's a lot of radiation to give them if they don't need it, straight to their brain. So really, really helpful and specific, NICE guidelines for people under 16. Like if they've done it, if these signs within 1 hour, these signs within 4 hours. So just take a really thorough history. Exactly when did they fall? Exactly how did they fall? How did they land? Have a little feel around the head, do a full neurological assessment, and so on and so forth, and then follow the guidelines. And I just wanted to signpost that, because I think if I'd used it more in my F1 years, I wouldn't have had so many sleepless nights about not CTing people that I should have, or worrying that I'm CTing too many people. So it can be really stressful making those decisions on your own, and hopefully you have a supportive med-reg who will guide you in your decision making. And of course, you always can do it if in doubt. But yeah, just signposting those for you. And I think I'm a bit early, but it hasn't come up on here, but I do have some questions on here on the Mentimeter. So it's more for my own helpfulness, but I've just got a repeat slide about whether you feel the same, or hopefully not, this has decreased your confidence in thinking about escalating and chest x-rays and things. Okay. A little bit better. That's great. I mean, it's such a short time and there's so much to cover. I really we can't cover everything, and I'm not a radiologist, so I'm not going to be able to teach you loads more than you already know. But I think my main points from this is just about thinking, you know, is this patient sick? If you're seeing kind of chest X-rays like massive pulmonary edema, huge pneumothoraces, or massive empyemas in sick patients, just think, do I need support? Get the med reg down. And if you're really struggling, you can just put out met calls. I think that felt really scary and overwhelming when I started as an F1. Oh, am I being really silly and over dramatic putting out a met call? But you're not. Sometimes you just need more hands, and it's, you know, you're not expected. I'm still not expected to manage all this stuff on our own, and it is so scary. So it's okay to ask for help. Is there anything you were hoping we would cover today that we haven't, that would be helpful for us to know? I know someone mentioned ECGs earlier, but we have lots of specialty teaching in terms of like cardiology and TNO and fractures and peds and stuff coming up. So I didn't want to go too much into specific specialties, but more just think about when to order, like going through a case and thinking about what should we do, how should we manage this. But if there's anything people were hoping we'd cover, there's nothing that's come up. Okay, and last slide is just whether anyone has any questions. I can attempt to answer. I'm not making any promises. Yes, there's I don't know why it hasn't come up. There is a QR code, which it doesn't seem to have. Oh, here it is. Yeah, scan that QR code, and put your name and email address in, and they send you a certificate of attendance. I think you can probably use it for your non-core learning. I don't know for sure, but probably yes. How would you manage apical pneumothorax if you're overnight looking at pacemaker adjustment? Great question. Apical pneumothorax. So it depends on how unwell the patient is what I would say. So if I'd seen one that was new, I would certainly speak to my reg. So if I was on a surgical, well, as cardiologist would be on a medical placement, I would call the reg and let them know. But if the patient is well, so most pneumothoraces, if they're small and the patient's tolerating it okay, you don't need to, they will just reabsorb on their own. But if it's getting, I would keep a close eye on the patient, monitor their obs. If it's getting bigger or getting worse, then it may be something that needs to be drained overnight. But first thing I would do is I would tell my med reg, and if they want to speak to the cardiologist. But once it's there, as long as the pacemaker's in the right place, is not, unless it's massive, there's not going to be anything much to do. It's going to be about observations and making sure that the patient isn't breathless. And then you would just manage it as with any other pneumothorax. So if it's massive, chest drain. But that wouldn't be a me or you job. Yeah. If in doubt, speak to your med-reg if you see anything. Okay, if there's no other questions, that's a QR code. Thank you so much for joining. Yeah, we really appreciate your time. I hope it's helpful. And we have a session on pharmacology and fluids next week with Maria. So hopefully we'll see some of you then. But we finished 5 minutes early, which is great. So enjoy the rest of your evening. I'm going to close this down if I can, and I'm going to stop sharing my screen. Fab. Thanks so much. Bye, everyone. I'm going to close the stream.